everyone, and welcome to our International Fluid Academy and the World Institute of Critical Care and Emergency Medicine webinar. We are very happy to have our third webinar for fluid management and resuscitation in critically ill patients. And as you know, there was 3 publications from the European Society of Intensive Care Medicine about the clinical guidelines and clinical practice guidelines for fluid management. We already conducted 2 webinars in the past, and this is the third one. Again, the 3 publications, the first was concentrated on the type of fluid management and resuscitation. The second part was about the volume and the amount of fluid that should be given. And today we are focusing on fluid removal and de-escalation. So this was our first webinar that was focusing on the kind and the type of fluid management. And this was the second webinar. So the first one was in May. Second one was in June, and Dr. Manu Melbourne, he invited always the first authors and the second co-authors of this publication. And today we have part 3 focusing on the de-escalation, and we are very proud to have Professor Marlies Osterman from London. She is the first author of the clinical practice guideline for part 3. And Dr. Faiz Al-Shamsi is the second author of the publication. Again, we also have Professor Ahmed Higazi from London, Ontario, who is a critical care expert and cardiac critical care, very well-known physician. So just as a reminder, resuscitation has different phases. So we focus in the past on initial resuscitation phase, optimization phase, stabilization, and today we are focusing on de-escalation. And here is the publication, the third one that is concentrated on the fluid removal. Again, we are going to send you the whole article for your reference. If you are interested, please go ahead and read it. It has a lot of details. So we'll try to cover most of the take-home messages and the clinical practice guidelines today. But if you need more information, you can go ahead and read the whole article. Again, Dr. Ahmed Higazi is going to give a very brief survey about the fluid management in your institution. So please try to be active, interactive, and get engagement with Dr. Higazi to answer his questions. Then Dr. Faiz Al-Shamsi is going to give a brief introduction about the methodology and future improvement of fluid management with the de-escalation phase. Then Professor Manu is going to focus on definitions. Then Professor Marlies Osterman is going to give the clinical practice guidelines. Again, this session will be monitored and will be led by Dr. Higazi and Dr. Manu Melbourne, and I'm going to give the closing remarks. Just some housekeeping stuff here. First, you need to activate the show caption option that you can see here in the lower part of the on your screen. You activate this show caption so you can see the transcription. Everything we say can be also transcribed on the screen. The webinar recording should be available tomorrow, so we are going to share with you the link, and you should receive attendance certificate by next week. Again, all of this knowledge and all of these educational activities has no value except we improve our patient outcome, except we put it in our clinical practice and improve our clinical practice. I'm going to stop by here, and I'm going to let Professor Higazi to share his screen and give you some survey questions.
Thank you very much, Amr. So I'll start off by asking you all to answer these questions. We have a bunch of questions prepared for you to spark your interest and introduce the topic of IV fluid therapy. And I'm glad we have the experts, the authors of the paper, the authors of the guidelines with us today. The first webinar discussed the drug and then the dose. And then this webinar discusses de-escalation. So let's start off with the first question. I'm going to ask you to all interact here. So the first question says, how many hours of education on fluid management in core MD curricula do we have? And please post the poll. It's either 0 hours, 10 hours, 15 hours, or 100 hours. How many hours of education do you encounter in your medical school education? Let's post the poll. Poll question. I'm waiting for the poll. So you guys just reflect on your own education and see. If we don't get the poll posted, I'm going to just reveal the answer. And it may be no surprise to you that in our medical school education, we get 0 hours of education on fluid management. So that's the first poll question. The second question, if we're able to pull that while I'm pulling it up. How many hospitalized patients receive IV fluids? Generally speaking, reflect on your own hospital, where you work. How many hospitalized patients in general end up receiving IV fluids? Is it 25%, 50%, 85%, or 100%? Are we able to get the poll running? This is pretty straightforward. So if you haven't guessed yet, I would guess, as far as I can tell from what I see in the hospital and in the inpatient wards, about 85% of hospitalized patients actually get ongoing fluids. I'll move on to the third question. So 85% is a huge number. Like, that's most of your hospitalized patients get IV fluids. So I think the onus is on ourselves to understand the guidelines, apply the guidelines, and that's why webinars like this are extremely important. The next question says, what is the amount of IV fluid creep, which is IV fluid used for drug and dilution, plus maintenance? So what is the average amount of IV fluid creep as a percentage of the daily fluid intake of patients? Is it 25%? Is it 50%? Is it 75%? Or is it 100%? So as you can imagine, about 50% of what a patient is getting per day is all just creep, is all just drugs and dilution. That's a huge amount. That's 50% of what they're getting, plus maintenance, obviously. So maintenance plus creep is about 50% of what they're getting. What is the average knowledge score on IV fluid management? Is it 25%? Is it 50%? Is it 75%? Or is it 100%? So the average knowledge score in IV fluid management is about 50%. So let's move on to the last and final question. How many hospitalized patients receive inappropriate IV fluids? IV fluids that are not intentional, like you don't intend this patient to get this amount of IV fluids. How many hospitalized patients, what is the percentage of hospitalized patients that receive inappropriate IV fluids that are not in keeping with your fluid balance target?
So it could be too little or too much.
Either too little or too much, absolutely. So is it 25%? Is it 50%? Is it 75%? Or is it 100%? Sorry, we'll remove this poll because this is not the question. Just one, I'll take that poll out. The question here is inappropriate IV fluids. 25, 50, 75, or 100. Too much or too little? Let's give an estimate. Put that in your mind. And drum roll, the answer is 25%. Yeah. Oh, there's the poll. Wow. It's awesome. So it's 25%. Yeah. So 25% of hospitalized patients receive inappropriate IV fluids. That's a quarter of your patients either receive too much or too little. And so I think this was a good introduction into how important this topic is. From this point onwards, I think we all need to pay attention as to how we're going to give fluid, how much we're going to give, and when it comes time to de-escalation, which is today's webinar, what should we do? So I'll hand it over to Dr. Manu Malbrain. Thank you.
Okay, thank you so much, Amr and Ahmed, for co-organizing these webinars, the last in the series. So without losing further time, it's my pleasure to introduce Fayez Al-Shamsi, who is the methodologist of these ESICM guidelines. And he will explain us a little bit how did we get there, what was the path towards establishing these guidelines. So please, Fayez, the floor is yours.
Thank you very much, Manu. Can you hear me?
Absolutely perfect.
Thank you. Hello, everyone. So this is, as Manu said, is a methodology primer or an update, a brief. So basically, this is the whole process of the guideline. As you can see, the committees and the priorities have been set up by setting the questions and the three parts. So we're in part 3. So this is an overall scheme of how we went from point A to disseminating it and publishing it, and we should in the future sometime update it if any evidence comes out. So the process the panel was delved in was basically formulating questions that are of critical importance to patients management in the format of population intervention, comparator, and outcome. The intervention here was removal of fluids, where the comparator was usual care. And we asked the panelists to provide the outcomes and rate these outcomes on a scale from 1 to 9. Can someone please mute?
I will come back with it. You want to do numbers on it?
There is noise in the background. Can someone please? Okay, sorry. So then the outcomes are prioritized by the panelists, and then I go and look for me and my colleagues. But in this part, I was with the methodologists. We look for the evidence after expert searches. We prepare summary of evidence. And then the first part of it is how good the evidence, which is the grading the evidence basically. And then after we grade the overall evidence, to go from only the evidence to the recommendation, there are other things to consider. They include the quality of evidence, which we spoke about. There is also the balance of benefits and harms, values and preferences of patients, the feasibility of the interventions, equity and acceptability. And then at the end, weighing all these together, the panel will come up with a recommendation, which either is a strong one, which means that for most patients, the benefits outweigh all the risks, or a weak one where in most circumstances it will be appropriate to use it, but in some circumstances the situation will be different. This is a grading process. That was where I just described what I did for the guidelines, but I will walk you through the 5 steps quickly. So for the outcomes, we encourage the panelists to choose hard outcomes like mortality rather than surrogate outcomes. For example, instead of myocardial infarction, we look at the coronary calcification or the calcium product. So these are more indirect, and if we only have outcomes here, we actually are less certain about how good the evidence is. So we might end up downgrading the evidence for indirectness. For risk of bias, the randomized trials start as high, well-conducted randomized trials start as high risk or low risk of bias and high quality, but they can be lowered down for any of those 5 factors, which I will speak briefly in one slide each. Inconsistency is basically when you do the meta-analysis of the results. And this year we see that although they are spread a little bit, but all the studies are next to the midline, so there's not much heterogeneity or inconsistency. Here, although they're not overlapping, but they're all at the left side, so they all favor the intervention. While on the extreme right, in fact, you see that they're on both sides of the point of no difference. So we suspect that the results are not equal or across all studies. So that's one aspect. We can either measure it statistically or we can do meta-regression. And then the next thing is the indirectness. It is at several levels. So it is either, are we looking at the same intervention that we are interested in that was done in the studies? Are we looking at the same population? Are we looking at the same dose and outcomes? And was the same comparison in the studies same as the one we intended or we wanted to? So moving from then we look at the imprecision. Imprecision basically is how confident we are in the overall pooled result. So here you can see the diamond is the upper end is a confidence interval. It's on the left side of the point of no difference, while here we see that it crosses. So here there is probably there's no difference, but overall when you look at the all groups, this diamond is on the left side. The other way to look for imprecision is to look at the numeric numbers over here, and they should all be at one side, either above or below 1. Next, we look at publication bias. As you know, negative studies are less likely to be published. So there is a way when looking at the evidence to see if there is we suspect that there is publication bias. So one is a visual inspection. So you can see that the studies are plotted with their precision. So the very precise studies are up here. There's larger studies up here, while smaller, less precise studies are usually at the bottom. As you can see here, if we examine these two plots, there is a void over here. So probably we suspect negative studies that were not published. So that is another thing where when we assess the body of evidence, we probably will take 1 point or maybe 2 points at a time when we suspect it. When we do all of this, we create something called the evidence profile, and you see the outcome here and all these domains over here. And then the panel, and this is what an evidence profile looks like. And we are transparent with all the domains, whether we downgraded or upgraded. And at the bottom here, we put the reasons if we downgraded for any reason. Now, what we spoke about is only the evidence, but to make a recommendation, the quality of evidence is one, but there are all other things to consider: the cost, the values and preferences. We said equity, feasibility, risk and benefit balance, and this is what we at the end makes a recommendation. We use what we call as the evidence to decision framework from the grade recommendation. It looks like this table, and we finally come up with the recommendation. As I said, this is what the panel goes through when voting on the desirable effect, for example, and so on. We're nearing the end over here. Basically, as I said, a strong recommendation. Most of the benefits outweigh any risks for most patients, while in weak recommendation, we're not very certain about that. I will leave this for reference. You can have details. This is for further reference as well. This is a free grade handbook with all the references embedded, so you can access all the details for your further references. And there's also a series of articles in Journal of Clinical Epidemiology on grade guidance for people who are interested. And finally, this is a favorite slide of mine, is that that no matter how strong recommendation or body of evidences, they should not be seen as dictates or mandates by anybody else, because no matter how much evidence there is, you cannot always account for the differences in specific patients in front of you. And with that, I will conclude my slide, and thank you.
Thank you so much, Dr. Faiz, for this methodology background highlights. And now it's Professor Manu turn. He has about 15-minute presentation, very nice presentation. Dr. Manu Melbourne was born in 1965 and was graduated from the Catholic University in Belgium, 1991. Then he completed his internal medicine training in 1996. He's the president of the International Fluid Academy and the Abdominal Compartment Syndrome Academy. He's very well published. He's a scientist, a clinical scientist, so physician, critical care physician, and clinical scientist as well. Over the last 3 decades, he delivered more than 1,000 lectures at national and international scientific conferences. Without further ado, I will let you to listen to Professor Manu's presentation.
I'm Manu Melbourne from Belgium, and it's my real pleasure to be here today for part 3, after we had part 1 on the drug and part 2 on the dose, with insights from the latest ESICM guidelines that were published in intensive care medicine. So now today we have part 3 on fluid removal at the de-escalation phase that has been accepted for publication. We will have as main speaker Professor Marlies Osterman, And we had Fayez Al-Shamsi talking about the methodology. I will now briefly tackle the definitions surrounding de-escalation and de-resuscitation, and then we will have the consensus guidelines. Now, we know that fluid management is very delicate, and we need to achieve fluid homeostasis, while too much fluids is bad for the patient. Hypovolemia is equally bad. So about 10 years ago, we had this debate on fate and evidence between hypovolemia, or Scylla and Charybdis, which brings me back to ancient Greek methodology and Homer's Odyssey. And when he was traveling the seas, at some point he encountered Scylla, which is a six-headed creature that would resemble hypervolemia. But he also had to pass Charybdis, which is like a vortex resembling hypovolemia. So when Homer was passing by Scylla Charybdis, he chose to pass nearly by Scylla, so he lost 6 of his men, but the ship wasn't lost and he could continue his journey. Now, why are we giving fluids? You could think of giving fluids to improve stroke volume, the macro circulation, but also tissue perfusion and microcirculation. Of course, it's both, as you need to have microcirculatory flow with a heartbeat, blood pressure, stroke volume, taking oxygen-rich blood to the microcirculation. Now, if we talk about fast fluid accumulation syndrome, it's a syndrome, not a disease. It can occur within many disease states and conditions. Now, I have to give you a testimonial in a confessional. Like this is a slide that was made by my wife of an ugly fluid. And I asked her, take this picture before I was undergoing major surgery. Now, about 4 days after the surgery, I gained 8 kilos. So I had fluid accumulation, pitting edema, as well as abdominal hypertension because of ileus due to opioid pain killers. You can see that the right hemidiaphragm is pushed upwards. There's a lot of air in the bowel. So I can tell you fluid accumulation syndrome as well as abdominal hypertension are real. Yet many surgeons and anesthetists don't pay proper attention to perioperative fluid accumulation syndrome. Let me illustrate with this typical patient: perforated viscous abdominal sepsis, back in ICU, and blood pressure is low, urine output is low, maybe CVP is low, or the patient is fluid responsive on a passive leg raise test. At the end of the day, we may have administered 5 bags of saline. Why? Because it's kind of a reflex. Whenever something goes wrong, we think that giving some fluids could be beneficial. Now, on day 2, we see the abdomen is distended with a rise in creatinine, and by day 4, there is a positive cumulative fluid balance, and the CVVH machine is running with ultrafiltration. Now, on day 7, the sudden cardiac arrest. So the patient had acute mesenteric ischemia, and this was caused by fluid accumulation syndrome leading to abdominal compartment syndrome. Now, intra-abdominal pressure is a killer, but the question today is, did you do everything to prevent fluid accumulation syndrome? And are we shifting our mindset and thinking fluid stewardship? Now, we're all humans make mistakes, but let's focus on the lesson. And for that, the Fluid Academy provides you some guidelines and guidance. One of the latest is this panel report on implementation of fluid stewardship. And for those interested, you can download your own copy PDF of the book on rational use of IV fluids with a dedicated chapter on de-escalation, de-resuscitation. And it has been downloaded almost 1.7 million times. So these are the problems with IV fluids, and that's why we need to change our mindset. We need to go for fluid stewardship, which is a systematic approach to reduce inappropriate fluid use, complications, improve outcomes, reduce costs. And this is in line with the guidelines. So it's all about the right fluid dose, rate, duration, de-escalation in the right patient for the right indication at the right time. Now, how many Ds does this fluid stewardship framework have? Well, we came up with about 10 Ds. I'm not going into detail, but let's focus on drug dose, duration, de-escalation. So we should only start when 6 conditions are met. Patient should be in shock. Patient should be hypovolemic. There should be signs of tissue hypoperfusion, lactate, CRT. Patient should be fluid responsive, fluid tolerant without the risk of fluid accumulation. Only if these conditions are present, you can give fluids. Now, the physician should check the 4 questions, which is when to start fluids, when to stop fluids, when to start fluid removal, and when to stop fluid removal. Now, 4 major indications: resuscitation, maintenance, replacement, and nutrition. But the 5th, it's not an indication, rather a consequence. It's to dissolve other drugs. Remember, all fluids are redistributed, so we have to reassess volemia status fluid responsiveness. Now, in this paper of over 10,000 ICU patients, Niels van Reger model found that only 6% of fluids are for resuscitation, 22 maintenance, and 33 nutrition, and also 33 is fluid creep, which is quite a lot. Now, you're never too old to learn, and I just defended my master thesis. Finished a master after master in insurance medicine, and here we looked at nationwide issuing of fluids in Belgium. It was hackathon data. We had over 4 million data lines and over 1.25 billion individual drug or IV fluid administrations. Now, annually in Belgium, we administer about 11 million liters of fluid, and you can see there for resuscitation, maintenance, creep, and nutrition. We see over time that the creep fluids are increasing, maintenance is decreasing, and the resuscitation is increasing. What does this mean? The resuscitation was retrospectively defined as isotonic solutions, so probably saline, Ringer's, Plasmolite, are administered for the wrong indication and given as maintenance. Now, if you look at the liters per patient, it's around 5.7 liters, and the liters per bed occupying day is still increasing if you look at the gray regression line at about 0.8 liters. Now, if we look in Flanders and Walloon and Brussels region, we see over time more admissions, but duration of stay is decreasing, and we see regional differences. Like in Flanders, we're giving more fluids per patient and per day. Now, if you look at the provinces, you can see that between 2007 and 2017, there is an overall increase, but you also see more red regions, which means that there is an increase over time. And on the bottom, you can see the saline use in liters per patient. And on the bottom right, it's the saline use in liters per bed occupying day. This is highly red. We are giving too much salt. Now, if we look at the trend, there is a drop in saline use, but still 65% of all isotonic fluids today is saline, and 40% of all fluids taken together, nutrition and the other indications. Now, let's focus on some definitions, because we need to speak the same language when we talk about de-escalation. Fluid balance, you know, is the daily sum of all ins and outs, and you can calculate it also in a cumulative way. Fluid overload, if you have this cumulative fluid balance, you divide by the baseline the patient's baseline body weight, but this is an old definition, and it was defined as an all or none phenomenon with a cutoff value of 10% fluid accumulation. Now, fluid withholding is your decision not to start IV fluids. Fluid retention is when our body is accumulating fluids. Fluid creep is a term that refers to the unintentional and unmeasured fluid volumes administered in the process of delivering other drugs like antibiotics, sedatives, painkillers, and so forth. Fluid tolerance is a new term that is defined as the maximum amount of fluids that a patient can tolerate without causing harm. Fluid restriction is a fluid management aimed at restricting daily amount of IV fluids, maybe because there is fluid retention, and conservative or restrictive fluid management is limiting the fluids to obtain a negative daily cumulative fluid balance, liberal standard. This will result in a positive fluid balance. Now, we have these terms like the early adequate goal-directed fluid management from the sepsis guidelines. Late conservative fluid management is defined as 2 consecutive days of a negative fluid balance within the first week. Late goal-directed fluid removal is the active fluid removal with diuretics or CVVH, and this is often referred to as de-escalation, but I would call this, because it's active, de-resuscitation. Now, global increased permeability syndrome is a patient with a persistent positive cumulative fluid balance and deleterious effects on organ function, like lung water, abdominal hypertension, and this can be accompanied with peripheral edema. So normally you have the ebb phase and you spontaneously transgress to the flow phase. When this does not happen, you will have a persistent positive cumulative fluid balance. And if this is associated with organ failure because of the accumulated fluids, poor source control and capillary leak, this is the Michelin Man or GIPS. Now, fluid withdrawing is reducing the dose or completely stopping previously started IV fluids. De-escalation refers to not initiating extra fluids, so the withholding, but also the withdrawing or the reduction of previously started fluids, while de-resuscitation is the correction of fluid accumulation syndrome with active removal. So the difference between de-escalation and de-resuscitation is that the passivity and the active fluid removal. Now, in all this, the fluid status matters, and it's important to understand the difference between osmolality, the number of osmoles driven by sodium, glucose, ureum, which determine the tolerability of a fluid, as opposed to the tonicity or the effective osmolality, mainly driven by the sodium, which will determine the distribution of the fluid. Now, we know that the human body mainly consists of water, the water being in the cells, and 1/3 out of the cells, with 1/4 the intravascular fluid. Now, if I would administer an isotonic solution, 1 liter, after 1 hour, only 25% will remain intravascularly of saline plasma-light ringers. A hypertonic solution is very good for cellular rehydration, but will only remain 8% intravascular, whereas colloids, like albumin, these fluids will remain at least 100% after 1 hour intravascularly. Now, we know that fluid overload leads to hypervolemia, hyperhydration, and peripheral edema because of hydrostatic forces. The opposite is not true. It's not because your patient is edematous that he is also hypervolemic. And that's why Jean-Louis Vincent suggested maybe we should avoid the term fluid overload. Everything you need to know is in this paper co-authored with Greg Martin and Marlies, and the follow-up review on fluid accumulation syndrome with Carmen Faulkner. So instead of fluid overload, let's talk about fluid accumulation, which is an increase in body weight or in cumulative fluid balance in relation to admission body weight. Maybe in the future there will be other technologies, but going back to the intra-extracellular water, when we talk about fluid accumulation, it's an increase in extracellular water, whereas hypervolemia is an increase in the intravascular fluids. Because of fluid overload, often misleading and interpreted as hypervolemia. That's why we propose fluid accumulation. And fluid accumulation syndrome is now not this 10% cutoff, but any degree of fluid accumulation with a negative impact on organ function. And this can be accompanied with global increased permeability syndrome, peripheral edema. So I told you everything you need to know is here, and it goes back to the Rose framework, where we try to give some tips and hints and triggers, targets when to start fluids, so the patient should be in shock. You stop fluids when there is no longer shock and the patient becomes fluid unresponsive. We start removing fluids when there is fluid accumulation syndrome or GIPS, and we stop removing fluids when, again, signs of hypoperfusion, fluid responsiveness appear. Now, it's very important to set your targets, choose your triggers and safety limits in order to reach the goal, which is to avoid this global increased permeability syndrome. Now, in this review paper, this is the visual abstract. So fluid accumulation syndrome is caused by the accumulated fluids. But when it comes to management of fluid accumulation syndrome, we should focus on prevention, care, and cure, and not going into details. But by doing so, we probably can influence outcomes of our patients. Now, going back to the Rose model and the 4 hits of shock, resuscitation fluids are for patient rescue. In the optimization phase, we aim for organ rescue. Stabilization, we support the organs, and during the evacuation phase, there is recovery of organ function. So hence the 4 phases within the Rose framework. It's very complicated because there is no one single study taking us to these different phases. So I just would like to end with presenting you what is in the pipeline with the Fluid Academy. We're developing the HemoGuide. So just to give you some flavor, HemoGuide will allow you to enter cases and hemodynamic profiles of patients. Within one patient, you can have different measurements. So we have some patient information, anthropometric measures, the hemodynamic parameters at a given point of time, whether the patient has sepsis or renal failure, ventilated or not, on inotropes. And once you enter that, you can calculate and you will get a complete profile on preload contractility, afterload, organ function, interpretation of volumes and thermodilution curves, and it will give you result of a decision support tool that was developed with random forest machine learning. And for instance, in this case, it will tell you that 95% of your colleagues would start removing fluids here with some inotropes, and for the presses, they are not sure whether to give them or not, so it may reflect a therapeutic dilemma. So more to come. Remember, it's a difficult balance between hypovolemia and hypervolemia. And I invite you to become a fluid champion now by taking the free online course. Thank you.
Thank you so much. Thank you so much, Professor Manu. And I'm happy, and I will have the chance. I think Dr. Manu is back with us. So Dr. Manu is going to introduce Dr. Marlies Osterman. Go ahead, sir.
Yes, it's my real pleasure to introduce a very good friend and colleague, Marlies, who is consultant in critical care and nephrology at Guy's and St. Thomas Hospital in London in the UK. And she's also director of research of the Intensive Care Society in the UK and president-elect of the European Society. Her clinical and academic interests are mainly critical care nephrology, sepsis, and extracorporeal organ support. So Marlies, we are thrilled to learn from you everything about the new guideline on fluid removal and de-escalation.
Thank you very much, Manu. It's a great honor to contribute to this important webinar, and I'm very grateful to you and your colleagues for organizing these webinars, because they really address a very important topic, the whole issue around management, starting, maintaining, and stopping. And here this afternoon, I'm presenting on behalf of the panel the final guideline related to fluid removal. Manu has given us a fantastic introduction outlining the complexity, outlining the reasons why fluid removal is important, and also the ongoing challenges. And it's very easy to follow on from this. I have no particular conflicts related to this talk. And as you've already heard, this is part 3 of the whole fluid guideline, with focus on fluid removal after initial resuscitation, including fluid therapy. And this slide really summarizes what we've already heard in this great talk by Professor Malbrain, that too little fluid is clearly harmful, but overdoing and giving too much is harmful to organs. Obviously, it leads to the question, how best to take fluid. Now, in real life, we really have mainly two ways. We can either use pharmacological measures, or we use ultrafiltration or renal replacement therapy. And most clinicians are very familiar, certainly with diuretics. Diuretics are widely available. They are non-invasive. They need either it can be given orally or intravenously, like peripheral line. And we are very familiar with them. But obviously the challenge is that the response may be unpredictable. In fact, some patients may not respond at all. Others may have a delayed response, leaving the patient fluid overloaded for longer. And also it has to be recognized that diuretics, like any other drug, have potential side effects. On the other hand, we have mechanical ways of removing fluid, either via ultrafiltration or using conventional renal replacement therapy machines. And clearly this has many advantages, because we can dial in, we can regulate how much fluid to take off. The response is much more predictable, but it's a huge step up in care. It's invasive, it requires a line, and has this form of fluid removal has many more potential side effects, and it clearly costs more, and it may not be available everywhere. But the question is one better than the other? Now, before I answer that, I want to go back to the fantastic talk which we heard from Professor Malbrain, And he alluded to one of the challenges. Although patients receive fluid and often need fluid as part of their resuscitation, the majority of fluid, as it accumulates, will be in the interstitial space. It's no longer in the vascular space. And so the challenge when thinking about fluid removal is that we have medications, drugs, or ultrafiltration that address the vascular space, but the fluid is outside, it's in the interstitial space. And with our devices or with our drugs, we can remove fluid from the vascular space, but we then rely on these fluid shifts. We hope that the fluid, which has accumulated in the interstitial space, will shift back into the vascular space. Now, fluid shift is physiological, it does happen, but it is limited. And in health, it's limited, but in health, maximum calories can shift a lot of fluid back into the vascular space. However, as patients get more sick, especially if they're critically ill, then the capillary refill rate goes down. And this means that as we remove fluid from the vascular space, there's a risk that the blood pressure may drop or patients become hemodynamically unstable if the capillary refill rate does not keep up, or if we remove fluid faster than physiology allows. Now, the tricky part at the bedside is obviously that we cannot measure capillary refill rate. So we use our clinical assessment and we assess the patient's condition in general. And the challenge, the sicker the patient, the more likely that they have vascular permeability, that their glycocalyx is disturbed and damaged, and that more fluid leaks out than shifts back. And that means that there is actually quite a high risk of hemodynamic instability during aggressive fluid removal. Certainly, if fluid is removed too fast, faster than capillary refill allows, the blood pressure may drop. The hemodynamic instability may also occur if fluid is removed beyond euvolemia. And again, this ties in with what Professor Malbrain said, that it's an active process and it requires continuous monitoring. The risk of hemodynamic instability is higher in patients who are vasoplegic and have severe vascular permeability. And it's also higher in those who have additional comorbidities like cardiac dysfunction, cardiogenic shock, or a low oncotic intravascular pressure. Now, all of this was taken into consideration when the panel got together to explore and assess the existing literature with the intention to develop guidelines for fluid removal. And as outlined, it was a very experienced panel with representation from all the relevant specialties, two clinical chairs who oversaw the development of all three parts, and a patient representatives was included to make absolutely sure that the guideline focused on patient-important outcomes. In many meetings discussing the importance of fluid removal, discussing the existing literature and the challenges, the expert panel agreed on three important questions. The first one essentially simply addressed the fact, is there a role for de-escalation of fluid therapy compared to no de-escalation in critically ill patients who are beyond the acute resuscitation phase and no longer need fluids? And the second question addressed the role of diuretics versus no diuretics. And in the third question, the panel focused on mechanical fluid removal using ultrafiltration or renal replacement therapy versus no mechanical fluid removal. It was very important to the panel to make sure that these were patient-important guidelines and that the recommendations would focus on outcomes that were relevant to patients. Therefore, the panel, this particular guideline, together with the members of the other two panels, got together and identified the key outcomes, together also obviously with the patient representatives. And it was felt that the outcomes as listed here would be important. But when it came to ranking and voting, mortality and quality of life were most important to patients, and also most important in the eyes of the experienced clinicians. And the same, this was followed by being functional, being active, and having cognitive function. And it was thought to be much more important than, for instance, vasopressor-free days or days in hospital. People were happy to stay in hospital for an extra day if this associated with, for instance, better quality of life. So mortality, quality of life, cognitive function, and being independent were considered to be the most important outcomes. Now, the panel felt that the guideline ideally should also look at particular subgroups and take into consideration that one size doesn't fit everybody, and that if possible, we should look at these different subgroups. Look at patients with and without hemodynamic instability, for instance, patients with or without cardiac problems, with and without severe respiratory failure, and with and without kidney problems. And this was very aspirational, but was thought to be very important to have an individualized, personalized guideline. Now, the difficulty then arose when the literature was searched and was reviewed. So almost 20,000 articles were reviewed, of which only really 24 randomized controlled trials made it to the pre-final selection. And of these 24 randomized controlled trials, really only 13 had appropriate information and met the criteria, i.e. looking at diuretics versus ultrafiltration, and with the particular outcomes in mind. Numerous papers, including randomized controlled trials, were excluded, and they were excluded because either they looked at patients who were not critically ill, or they were not randomized controlled trials, or they were secondary analysis of previous randomized controlled trials. So in the end, the best randomized controlled trials, these 13 were analyzed. And now I want to show them to you, really to highlight the challenge. Here we have these 13 randomized controlled trials, which were considered to be the best to answer the 3 PICO-PIC questions. And they go back to 1992. I've listed them here chronologically. And clearly in 1992, clinical management was different from what we do now at the beds. Anyway, these were the randomized controlled trials. The next thing you see is that they all looked at critically ill patients, but they looked at different types of patients, with and without sepsis, on the ventilator or not, with and without acute kidney injury. Furthermore, they all used different protocols. So in the intervention arms, they used either diuretics or ultrafiltration, or diuretics with ultrafiltration, or diuretics with fluid restriction, or simply diuretics alone. And even in the control arm, there were differences. Some studies, some protocols allowed the use of diuretics or renal replacement therapy, and others didn't. And this made it clearly very challenging for the evidence review to do the meta-analysis, but they did. But I want to highlight these are the challenges of the existing fluid removal studies. Now, I outlined the fact that we made a lot of effort identifying patient-important outcomes. When it came to the studies, sadly, quality of life or cognitive function was not explored. They all looked at mortality as an outcome, and some looked at renal replacement therapy, need for renal replacement therapy, but they did not look at any other important patient-important outcomes. So we couldn't really comment on this, although this had been our intention. So there was, in the existing pool of randomized controlled trial, there was a high risk of bias. There were a lot of studies where protocols were not adhered to. There was deviations. There were in both directions where patients were in control arm still received renal replacement therapy, or the other way around. People were in the intervention arm but didn't get the diuretics as per protocol. There were a lot of withdrawals and overall a high risk of bias. And the final challenge was the fact, again, alludes or comes back to what Professor Malbrain said, that fluid removal is part of this dynamic management and really needs to start at the right time. If it starts too early, when patients still need fluid resuscitation, then clearly patients may come to harm. But if it started too late, then patients are exposed to fluid overload for too long. However, none of the studies which we looked at, and also as shown in the previous systematic review, really looked at readiness for fluid removal. And some of the adverse events which we saw in these randomized controlled trials may simply be that the timing was not right. But this is essentially a fact of the existing literature and existing trials. So we were left with 13 trials. We acknowledged the limitations and challenges, but we were determined to develop some guidelines for clinical practice. And the search was then finally updated early this year. And based on the existing meta-analysis, recommendations were made. So I'll take you through the 3 PICOs. The first PICO addressed simply the question, is there a role for de-escalation compared to no de-escalation? Now, pooling the data of 13 randomized controlled trials, there was no sign of any difference in mortality. And even when the studies were excluded, where fluid deresuscitation or removal had been combined with fluid restriction, there was no real difference. But there was a difference in ICU-free days and also in the number of ventilator-free days. And based on these important outcomes, so less time in ICU, less on the ventilator, but no difference in mortality, the expert panel, together with the patient representative, felt that there was a role for de-escalation. And therefore, the team suggested de-escalation of fluid therapy over no de-escalation in patients who have passed the period and the phase of fluid resuscitation. The second PICO addressed and focused on diuretics. And for this PICO, again, 13 randomized controlled trials, all 13 randomized controlled trials were analyzed. Again, there was no difference that diuretics made a difference regarding survival. There was no evidence that they made a difference regarding the risk of needing acute kidney injury. But there was the difference with regards to the chance of receiving renal replacement therapy. And this was lower compared to, in the diuretic group, compared to patients who had not received diuretics. And this was considered to be a very important outcome, especially since renal replacement therapy is expensive. There are countries in the world where patients have to pay out of pocket, leading to potential rapid poverty. It's a therapy that is associated with a high workload. And based on this, based on the fact that replacement therapy could be avoided, the expert panel decided to issue a recommendation to suggest protocolized fluid removal with diuretics over no diuretic use. And then finally, the third PICO question focused on mechanical fluid removal using either ultrafiltration or renal replacement therapy. Now, to answer this PICO, there was only data from 4 randomized controlled trials available. And they, again, showed no difference in survival. And they really showed no difference when it came to any other important outcomes, patient-important outcomes. And based on that, the expert panel felt that they could not recommend the routine use of mechanical fluid removal or renal replacement therapy over diuretics. Now, I'm coming to the end of this presentation. I mentioned that we had intended to look at various subgroups, patients with and without AKI, renal respiratory failure, and so forth. It was not possible to do this because these randomized controlled trials did not have sufficient data really to look at any subgroup in more detail. And this brings me to the end. I want to emphasize what has already been said. De-escalation is an active process. There are data in the literature, but they're very heterogeneous. They've used different protocols, and they have a lot of limitations and challenges. But based on what we have at the moment, diuretics can be recommended over routine ultrafiltration. Now, I've given you a little snapshot. The whole paper is obviously available here. And I thank you very much for your attention and for taking part in this webinar. Together, we have to move the field further and advance this topic. Thank you for your attention.
Thank you so much, Marlies, for this excellent overview. I see there are a lot of questions in the Q&A, and I would like to kick off with one question for you, Marlies. When we talk about diuretics, could you elaborate a little bit on a test that you, as a nephrologist, know very well, which is the frusemide stress test, which is one, and then second, some patients may be responsive to diuretics initially, but on day 2 or 3, they may become resistant or diuretics will be no longer effective. So what would be your advice on the frusemide stress test and resistance?
Sure, very important topic. So the frusemide stress test is a diagnostic test. It was developed by Professor Chawla in Washington, when he was still in Washington. And it's a standardized diagnostic test to assess the health of tubular cells. The diagnostic test consists of a challenge with frusemide, which is 1 milligram per kilogram in those who've not had diuretics before, or 1.5 milligrams per kilogram in patients who've had diuretics before. So a standardized dose. And it gets given to patients with acute kidney injury, with a moderate or severe acute kidney injury, to assess whether the tubular cells are still healthy and functioning. If a patient passes 200 mils of urine in 2 hours immediately after having received the frusemide, then this is an indication that the tubular cells are still healthy or have recovered, and that there's an 85% chance that renal replacement therapy will not be needed. On the other hand, if patients can't pass this amount of urine, then there's a more than 80% risk that renal therapy will be needed because the tubular cells will continue to deteriorate. So a diagnostic test. On the other hand, obviously, we use diuretics as a therapy, and this is what the guideline relates to. And diuretic resistance simply incorporates 2 things. Patients may not respond to the dose chosen. The dose may be too low, maybe inadequate, or patients have side effects and the drug has to be stopped. And what I do, and then what I really do in clinical practice, if patients still have, if I think that if there's still some urine output and I give diuretics and it increases a bit, but it's not sufficient, I may look for other tools to improve this diuretic responsiveness. And that could be adding a second diuretic, some sequential therapy, or increasing the dose, or making sure that the blood pressure is actually okay, or improving renal perfusion pressure. But as I look at other ways to improve responsiveness, and if I really have optimized everything and the patient remains overloaded and is accumulating fluids and coming to harm, then I would quite rapidly go to mechanical removal.
If I may, just to elaborate a little bit on that, as we know that furosemide is the main diuretic given, and its effect may be dependent on albumin.
Mhm.
We know in fluid accumulation that there may be hypoalbuminemia. So would you advocate like restoring albumin levels when we are diuresing?
Yes, so this is hyperalbuminemia is one potential reason for diuretic resistance. And in those with an albumin less than 30, who are fluid overloaded and responding to furosemide properly, then I will give some albumin as well, yes. But obviously this is to combine with optimizing everything else. It will not work if the blood pressure, if the patient is hypotensive, or there are other confounding factors. But as part of this, yes, I would give albumin.
Okay, so now I would like to hand over to Ahmed or Amr or Fayez, if you want to shoot any questions.
Yes, I'd like to jump in if you don't mind. So I really loved both presentations. Thank you both. I like particularly the definitions, and I like the succinct guidelines and the points and the recommendations made by the committee. There's one question that jumped out from the audience, and that relates to Marlies, Dr. Osterman's talk about none of the studies really defined at what point is it appropriate to start de-escalation. And the question from the audience here says, is there a best parameter to tell us, in your practice perhaps, if there's no real evidence for it, but what is the best parameter to tell us that we can start de-escalation and this is the right time for it?
Yeah, so it's a very good question. I think actually Professor Malbrain is the best person to answer this because he's written about this extensively and has developed algorithms and guidelines about this. So, Manu, I'll give it to you.
Yeah.
Because you're the expert here.
Well, I don't think there is one single parameter for starters. I also want to state that some patients thrive very well with some accumulated fluids. They are on 1 liter of oxygen, they are doing fine organ function wise. So the normal situation is that you transgress from the ebb to the flow phase and that you eliminate the excess of fluids that have been given. And this is what you see in acute tubular necrosis. You have a polyuric phase and then everything returns back to normal. So I would state that only when there is fluid accumulation syndrome, and with the stress on the syndrome, which means that the accumulated fluids cause harm with respect to organ function. And it could be increase in lung water, it could be, as was my personal case, increase in intra-abdominal pressure, could be venous congestion that you can assess with the VEXA score, or a combination of different parameters. I think is also within the poll, if you're living in a low middle income country and you don't have fancy monitoring tools and you can't perform transpulmonary thermodilution, what would be the best single parameter? I would say try to do your best as possible to have daily body weight, at least. Because if it increases with 5 kilos in 2 days, it's probably water and not muscle nor fat. Second, ask your nurses to do as good as possible a daily and cumulative fluid balance. And it's damn difficult to do this correctly. So you already have 2 parameters. If you can, and it's really not expensive, is bioelectrical impedance analysis, which will tell you where the fluids are going. Typically in accumulation, you see the intracellular water decreasing, the extracellular increasing, and you have a volume excess, which is a kind of a surrogate to a cumulative fluid balance. So if you would have those 3 to confirm your accumulating fluids, and if you would have another single parameter looking at the impact on organ function, I guess abdominal hypertension or a PF ratio, those are simple things with a chest X-ray, with point-of-care ultrasound to look for B lines, to check your venous congestion, and based on that, you can make a well-concerted decision that at least you should think de-escalation. And de-escalation is passive, and it starts the moment you're giving fluids. You must think, when shall I stop? And when shall I restrict or withhold or withdraw? So it's not one size fits all, but it's a combination of measures that some patients will need and others will not. And in some patients, you need to give it early, you need to do it aggressive, fast, and in others, just wait and see for them to enter the flow phase themselves. So it's a difficult question. There is no real answer. We are living in the Western world, so we have fancy monitors. But if you're in a low middle income country, these would be my 50 cents for doing at a bedside on a daily basis.
Excellent, thank you. Over to you, Amr.
I just have one more question for myself before we close. I haven't heard about we have Ahmed Higazi here, he's a cardiac critical care physician, about the heart function, the echocardiogram, the point of care ultrasound when it comes to the left ventricular assessment, the volume overload assessment. So what do you think, Ahmed, we need to learn from you?
So in my practice, I use ultrasound very heavily, and I use it to assess both volume responsiveness and volume tolerance. And by volume responsiveness, as was alluded to, it's benefited. It's an increase in cardiac output by administering volume, whereas volume tolerance means harm. You're actually going to cause organ congestion with excessive volume. So when it comes to volume responsiveness, I look at certain parameters. I look at the end diastolic area of the LV. I look at the IVC and obviously take it in context. I don't look at the IVC in isolation. The IVC is definitely not the holy grail. There are lots of other parameters that need to be taken into consideration. I also look at, I depend mostly on dynamic parameters. The passive leg raise is something I will turn to if I have questions. And I do that by lifting the leg of the bed, not the leg of the patient. So the bed itself, the leg of the bed itself needs to go up, and then I have an apical 5-chamber view looking at my LVOT and my LVOT VTI. And within 1 minute of leg elevation, I'll check again if the LVOT VTI has increased with that leg elevation. There's also the ventilator interaction with the patient's circulation that also can give me an idea, but you need to also have echo with it. It's not on its own, it has limitations. That's with regards to volume responsiveness. And then volume tolerance, you look at harm. I will look at typically B lines in the lungs. I will look at things like the VEXUS score and whether there's evidence of congestion of the abdominal organs, the kidney, the liver, the bowel. And I will look at the RV as well, because if your RV is big and dilated, this patient will not tolerate volume. In fact, you will cause harm by giving more volume. And so I use it for, in the initial phase, for both volume responsiveness and to assess whether harm will be occurring from volume, and this is what we call volume tolerance. I hope that sums up the answer. I have a more elaborate talk on this at some point. Maybe we can go through it.
I agree. Amr, if I may just add on that, volume responsiveness, fluid responsiveness is the normal situation. We are all fluid responsive. So I'm pretty much a fan of looking at fluid unresponsiveness, so a negative passive leg raising, PPV, which is very low, which gives you a kind of a safety indication that this patient will tolerate de-resuscitation or fluid removal. So we should not focus on fluid responsiveness, but more on fluid unresponsiveness and the other things that you mentioned.
Thank you so much, Professor Manou. Thank you so much, Professor Marlies, Ahmed, and Faiz. It's a great webinar today. We have over 400 attendees. I think we all learned. And the collaboration between the International Fluid Academy and the World Institute of Critical Care and Emergency Medicine is amazing. And to have both nephrologist and critical care physician, I love to have this combo. So I didn't feel alone today. I have Dr. Marlies with me with nephrology background training. So this was great. I think we need to do more and more of this collaborative work in the future, if you agree, Professor Melbourne. So it's not only about fluid, but we have a lot of other aspects to cover. So thank you again, and thanks for the attendees. All the attendees should receive their attendance certificate by next week, and everyone should have an access to our YouTube webinar recorded video by tomorrow. So thank you again, and have a good day, good afternoon, good evening, everyone.
Yes, with pleasure. And stop using too much saline. Definitely not saline 10%, as I saw in some of the questions.
Thank you.
Thanks. That's perfect. Thank you so much.